Last Friday, we looked at two articles that were comparing Medicare's Part A insolvency, and another article about durable medical equipment and the fraud involved in it. So, when we're looking at trust fund depletion dates from payroll taxes maybe being increased and the politics behind that, those type of conversations really do matter. But I think there's more than just that as a foundational pressure that's building that I'm not hearing people post articles about. And really, that's the workforce capacity to pay into the aging baby boomer generation. This is Ansall with an Ansall thought that's about 6 or 7 minutes long. Let's jump into it. All right, so zoom out with me before we get to the meat of where I'm going so you can kind of follow me on my train of thought here. So right now in the United States, we're adding roughly 11,000-ish Medicare beneficiaries every single day to the Medicare pool. The baby boomer wave right now, it's still moving through the system, and it's only increasing every year up until the early 2030s. At the same time, the American medical colleges are projecting that we have a physician shortage of up to 86,000 doctors by mid 2030. And that includes tens of thousands of primary care physicians and then specialists as well. And this isn't like some fringe estimate from these medical colleges. This is modeling from their mainstream working projects. So if we combine these two trajectories, right? The Medicare population, more Medicare beneficiaries are coming in, and at the same time, there's fewer physicians per capita that are coming in through the colleges. Layer that on top with Medicare reimbursement trends. Over the past half decade, we've only seen reimbursement from CMS go down. It was only this past year, MedPAC released that CMS gave a higher inflation increase to physicians. And even when adjusting for inflation, those physician payment rates, they've effectively declined in real terms over time. So the foundational tension then we're dealing with here is as the Medicare population grows, the provider supply growth is constraining and the reimbursement growth is continuing to lag significantly behind inflation. Now, that combination matters, and I would say it matters more long-term than the trust fund headlines that you're hearing about. Now, hospitals historically will offset those lower Medicare margins with higher commercial insurance payments. MedPAC has consistently shown that Medicare margins for hospitals on average are negative, while those commercial margins are higher. And the commercial margins, that's speaking to me and anyone on a group plan or the under 65 market. What happens though when Medicare beneficiaries become a larger share of the total patient mix? Well, that cross-subsidy math is going to continue to tighten and restrain. And when those margins tighten, we're going to have to see behavioral change amongst physicians and hospitals. Providers may start limiting the amount of new Medicare patients that they take on, or consolidating into larger systems, which only adds to vertical integration, or shift towards employment models for group coverage or under 65 coverage, or maybe some kind of value-based arrangement, or even retire earlier than expected. So we're already seeing consolidation accelerate across healthcare. So the AHA, the American Healthcare Association, they track decades worth of hospital mergers, and the physician employment model has shifted dramatically towards health system employment rather than going out on your own, becoming a W-2 of some kind of hospital system. And what I'm talking about isn't like a sudden collapse scenario that starts tomorrow, but it's gradually increased every year, this tension. Now think about how this plays out differently inside of the Medicare Advantage versus traditional Medicare market. MA plans, they've got several levers. They can negotiate contracts above what traditional Medicare reimburses. They can just build narrower networks, implement some kind of value-based payment model, or use utilization management with prior authorizations, and coordinate their care delivery amongst the primary care and referral needed for a specialist. Original Medicare can't do these things. Fee-for-service framework has far less levers over provider organization. So as workforce capacity tightens and the baby boomer generation ages into Medicare and onto Medicare, the system that coordinates this supply whichever one can figure it out first is going to have a great advantage. Now, that doesn't mean that Medicare Advantage is going to win here. It means that the workforce pressure could indirectly influence how our care gets organized. If we look at another geographic disparity, the National Center for Health Workforce Analysis, they documented uneven distribution of providers across rural areas versus urban areas. And as these older physicians are retiring, more rural access may become more strained and probably will than urban access. That means Medicare access pressure then for those who don't live in urban areas won't show up evenly across county to county estimates. Some regions are going to feel it way sooner than other regions. So let's look forward a decade and a half from now. If reimbursement growth continues to lag inflation and physician practice cost growth, and if physician training slots aren't expanding meaningfully and colleges aren't seeing growth in these areas, and then if the demand continues with baby boomers coming onto Medicare, we may not see Medicare fail financially first. We may see the whole system collapse. You're going to see longer wait times. You're going to see tighter networks. You're going to see more managed care coordination. You're going to see increased consolidation and regional access disparities. That's coming. It's too late to change that. This is a structural outcome that we should have looked at a decade or two ago. And I'm not trying to be dramatic here like some of the headlines we read, right? I'm just making the point that the pressures that we're not solving aren't going to be solved by adjusting payroll taxes alone. This is going to require workforce policy and reimbursement reform, a graduate medical education expansion, and then the whole system being redesigned to fit this structural problem. So when we're talking about Medicare's future, the question's not only can Medicare pay? Well, yeah, I believe Congress will always fund that. I think the broader question, the more impactful question is, will there even be enough providers to participate? Because that's the longer game right now, that variable. And that's the pressure that I think we all should be paying attention to as Medicare continues on, into its future.